There are a lot of age-related macular or eye changes that occur in a person. One of the leading causes of blindness is the age-related macular degeneration that we talked about. So the normal or the physiological changes that occur according with age is the nearsightedness, that is again very important, or the short-sightedness, that is again very important, and presbyopia is a very common feature that is seen in the old age people. So having a presbyopia is quite normal, and that is not going to affect very much in the day-to-day activities of the individual. But age-related macular degeneration is one of the leading cause of the blindness in the old people. So one should know how to go about and treat this age-related macular degeneration. Then what are the clinical features of this age-related degeneration that we also have to know. So if you have a patient of old age and he comes up to you and give you an history of blurring of the vision or a decrease in the visual acuity, what are the common tests or the features that you're going to see? What is the differential diagnosis that you have to keep in your mind? The differential diagnosis would obviously consist of even the other causes of the blindness that we've already gone through, ranging from the infections, that is the trachoma, then we have the onchoriasis, we have the syphilis, leprosy. Due to the decrease in the immunity by the old age, you basically have a decreased immunity and you're more prone to getting these infections. So knowing the infectious state of the individual is again very important over here. Then one of the leading causes of blurring of the vision is the cataract in these individuals with old age. So cataract has to be excluded over here, and then we're going to go about and evaluate the patient for glaucoma. Glaucoma is one of the leading causes of the blindness. And then we have the diabetic retinopathy, which has also to be evaluated for when you have an old age patient who's also suffering from diabetes. So taking the history in this particular patient is the mainstay when you're going to start off with the management in this particular patient. History taking would start off with the particulars of the individual, and then you're going to move on to the presenting complaints. Presenting complaints would obviously include the onset and the duration of the complaints, and then you're going to move on to the history of the presenting complaints. Then you're going to move on to the medical history, which would include any history of diabetes, hyperlipidemias, or hypertensions, etc. And then if any other infectious diseases he had encountered in the past or in the near past. Then the surgical history would be evaluated for any surgeries or the use of the contact lenses if he has. Family history for the macular degeneration, retinal detachments, strabismus, glaucomas, all of these have to be evaluated in that particular person that we're talking about. So the different causative factors, we're going to discuss them over here along with the macular degeneration, which are associated with the macular degeneration. Then we're going to move on to the risk factors that can make the person more prone to the development of macular degeneration. Then we have the prognosis. When we have a diagnosed case of macular degeneration, what is the prognosis after the treatment has been started quite vigilantly? What are we going to expect in that particular patient? What are the outcomes for that particular patient that we're talking about? So the leading causes of the blindness, they include the age-related macular degeneration is a very common cause for the blindness. It is usually abbreviated as AKA, AMD, ARM, SMD. So these are the usual abbreviations that are used. You have to distinguish between the dry macular degeneration from the wet macular degeneration. It's again by the ophthalmoscopy. We have the atrophic versus the exudative type. On one hand, we have the atrophic type, that is again age-related. The exudative type, that is again quite infectious type, which is basically superimposed by infections over here. So the most common cause of blindness is the age-related macular degeneration. The dry form is the most common form, being almost more than 80% of the people who are presenting with macular degeneration are relating to the dry form of the disease. So usually the form that we encounter is the dry form. 88% have the exudative disease as well. So the risk factors have smoking, 2.5%, basically increases the risk more, that is almost 2.5% fold. And positive family history is again one of the risk factors that is going to make the person more prone to the development of macular degeneration. The other risk factors would include the sex of the individual, the diet that he's on, the eye color, the hypertension, then the cardiovascular diseases. So the history taking is again very important. The documentation of the history is again very important when you have these diseases at your hand. You're going to ask the patient for any history of chronic illnesses such as diabetes, glaucoma, hyperlipidemias, hypertension, or any cardiovascular diseases. Unilateral disease risk is to the other eye is more. The incidence of 12 to 15% per year for 60 to 69-year-old people. Now, when we have a look at the prognosis in these individuals, the success of the laser treatment is more the vision 2 years after the randomization to the treatment, or observation that is subfoveal lesions is again very common. So if we have a look at this tabulated form of the deterioration in the vision, it's basically what is happening over here is if the person has less than 2 lines, it is treated almost 33%. The observance rate is almost 18% over here in these individuals. If the person is reading almost 2 to 3 lines, he's treated 23%, and observance is almost 17% in these individuals. 4 to 5 lines, the treatment is almost 24%, and the observance is 28% in these individuals over here that we're talking about. If the patient is reading more than 6 lines, the treatment is at the level of 20%, and the observance over here in these individuals is almost 37%. So this is the normal success rate for the laser treatments if they are performed for the macular degenerations in the individual, and the vision is 2 years after randomization to the treatment, or the observations or the subfoveal lesions are again very important over here when we are discussing these individuals. Now, there are a lot of additional tests that are performed for the macular degeneration. That includes the topometry. Topometry is this test that is seen over here. These are the results of the topometry. What is basically evaluated over here is the visual field. So you ask the patient continuously, and the defects in the visual field are mapped on a sheet of paper, and this is how you know what visual fields are affected in that particular patient that we are dealing with, and the treatment basically depends upon the results of this topometry. Then we have the anterior chamber depth assessment that is also performed in these individuals. That is basically going to indicate towards the dry form of the disease. Then we have the confrontation visual field. That is basically a subjective test in which the examiner also is going to evaluate his or her visual field. And then we have a comparative study between the examiner and the patient. The color vision testing is performed by Pierre-Robinson's test. And then we have the fluorescein staining. That is done for a lot of individuals. In these cases, the upper eyelid inversion can be done just to see the health point of view, or just to indicate whether it is the dry form of the disease or the wet form of the disease. So in this section, basically, we summarized the macular degeneration, which is basically age-related, and what are the treatment modalities and what are the additional tests that are going to be performed for such patients. So that is the end of the section. Thank you for watching sqadia.com.